Good morning, everyone. Welcome to Friday Chalk Talk. My name is Patrice Fidel. I am the lead advanced practice nurse here at Aurora Palliative Care. Today, I have the pleasure of introducing Dr. Lindsay Vendetta. Dr. Vendetta is a recent graduate from University of Washington's Hospice and Palliative Care Fellowship Program, and now practices palliative and geriatric medicine at VA Puget Sound Healthcare System in Seattle. See, messed it up anyway. Her academic interests include exploring the intersection of advanced care planning and serious illness, communication, and teaching others to explore and document values, goals, and preferences curiously and effectively. She's here today to talk about an educational piece that she co-authored right after her fellowship entitled The Role of the Palliative Clinician in the Family Conference. So I will turn the floor over to you, Lindsay. Thanks for being here.
Thank you, Patrice. I'm very excited to be here with you all today and excited to talk more about the role of the palliative medicine clinician in the family conference. Even though I did share my thoughts on this topic in writing, I haven't really had a discussion about these ideas with a group beyond my mentors and co-authors. So really looking forward to the discussion part at the end to hear your thoughts, additions, suggestions. I have a blank piece of paper, so I'm ready to take your notes. I'm going to start by sharing my personal inspiration for this topic, which quite simply, if you asked me how I felt about leading or attending family conferences as a third-year internal medicine resident or even newly minted hospitalist, I would have shared these sentiments with you. But when I moved on to palliative medicine training, I felt more like someone with a minor identity crisis. It was challenging enough just to introduce that nebulous role of palliative medicine fellow at the meeting, let alone know how to contribute with this new specialist title. I wanted so badly to add value to these intimate and life-altering meetings, but I worried that I was just a bystander. I mentioned this insecurity to my attending, Dr. Susan Merrill at the time, and she validated that there might actually be a knowledge gap on this topic. So I'm excited to share with you all today some of what I learned by doing a deep dive into this topic and attempting to develop a guide for how a palliative clinician can and should be contributing to family conferences. I should acknowledge here that while at face value, this might seem like a niche topic for early career palliative providers, I do think this conversation is applicable to all members of the transdisciplinary palliative care team. I also think exploring this topic together will make us better educators too. So with that, here's my quick roadmap for this morning's talk. We'll get some definitions out of the way, spend a few minutes on why we care about having high quality family meetings and what educational resources are available to us. And then we'll dive into the meat of the topic, which is outlining specific ways the palliative provider can contribute to the different stages of the family conference. We'll talk about how we can tailor this guide to real world situations, and then hopefully we'll hear from you. Here are two important definitions to get us on the same page. I'll say family conference and palliative clinician a lot. During this presentation, this is what I mean. A palliative medicine clinician is a physician or an APP with some training in palliative care. And a family conference is a meeting between a care team and a patient and/or the family, which addresses the patient's current condition, values, and treatment preferences. So why do we care about having high-value family conferences? Well, we know that family conferences can help build trust and rapport, as well as facilitate an exchange of information and shared decision-making. A well-run family conference is associated with improved patient outcomes, such as reduced ICU length of stay and lower levels of family psychological distress. And then what's out there in terms of family conference education? When I started my literature review to help identify specific ways palliative palliative consultants could contribute to family meetings, I found that most of the literature focuses on effective models at improving end-of-life communication. So for example, say more empathic statements or allow more space for silence, but they didn't really focus on palliative team logistics of the meeting. And then in terms of structuring the conference, most educational articles and videos address how to conduct the conference by leading from a generalist or medical trainee perspective. This image from Vital Talks framework for leading the family conference is a resource that I was first introduced to as an internal medicine resident and found very helpful. But as I mentioned earlier, by the time I was a palliative care fellow, I found myself looking for a more specific framework for people in my position. Even though my initial literature review contained helpful information regarding why we have family conferences and how to optimize communication, I still had some unanswered questions I wanted to address. Like, what's the approach to a palliative consultation when the specific ask is to attend a family conference? How do I approach leading versus not leading the conference? When I'm not leading, when and how do I provide input? What are redirection skills I should know? And then I had questions about how to best collaborate with other teams, as well as the palliative interdisciplinary team. So the content that I'm going to share on the next 4 slides is information compiled from a more focused literature review that sought to answer some of these questions. We ended up researching papers that explored family conferences, plus at least one component of education, communication, specialist involvement, or already published frameworks. And then I should also point out that my co-authors and I used our own experiences to help inform some of these recommendations as well. So starting with step 1, how to best prepare for an upcoming family conference. The most important action here is to complete a palliative consultation, ideally a day or 2 prior to the meeting. This is the ideal time to introduce the palliative care team, get to know the patient's illness perspective, their personhood, and their values. You can specifically ask about hopes and worries as they relate to the upcoming meeting, as well as learn more about the patient's agenda for the meeting. Going one step further, the initial palliative consultation serves as an opportunity to assess social, cultural, and religious practices that might impact the upcoming meeting. Like, are there preferences around the communication of medical information that might be helpful to know up front? Or preferences around talking about end of life? Do we know the patient and family's approach to decision making? Do we need a plan for an interpreter? And then lastly, regardless of being able to complete the initial consultation or not, we should be assessing and potentially advocating for certain voices to be present for the family conference. This might be the patient's surrogate, their bedside nurse, trusted PCP, paid caregiver, members from the patient's religious or cultural community. Generally, and definitely ideally speaking, I think we should be thinking more outside the box here. And then the palliative medicine clinician should also assess which other members of the interdisciplinary team should be present. In terms of attendees, a few helpful points I learned during this literature review are that 1, social workers and chaplains are often perceived as having a more neutral presence during a family conference. And 2, if possible, the number of medical attendees should be about equal to the family and community members involved to help break down that power differential that might exist. Moving on to best practices for the pre-huddle or step 2. Ideally, this will occur with the medical teams right before the family conference and should take about 10 to 15 minutes. This venue provides an opportunity to clarify the agenda prior to the meeting and to discuss sensitive details of the case, which may or may not even be recorded in the medical record. By creating a safe sharing space prior to the meeting, the palliative provider can start to tune into any distress that might be present among the medical teams. And then a few other tasks that I've added to my pre-huddle checklist are ensuring that I know the patient's legal surrogate ahead of time and clarifying the logistics of the meeting, like who will be leading the conference, and deciding ahead of time if there's a clear headline we'd like to share, which is often the case. And then another aspect of role clarification that I've learned is to state preemptively that if I'm not leading the conference, that I'll be ready to help and may even interject if I notice an opportunity for optimized communication. This also helps establish an environment of psychological safety. And I try to make clear to the leader that it's impossible to pick up on all opportunities for optimal communication. And so if I jump in, it's merely a signal of collaboration. If there are trainees participating, I try to learn about a specific skill that they'd like to work on, such as responding to emotion or sharing that headline. This helps me give them focused coaching and then ultimately more valuable feedback at the end of the meeting. And lastly, it's helpful if the palliative clinician is prepared to facilitate the meeting in the scenario that no one volunteers or feels comfortable, depending on the complexity of the case. I know I've learned this lesson the hard way, and so I definitely wanted to add it to my best practice guide. Okay, we've made it to the family conference after doing a lot of preparation, which is definitely a key takeaway point today. So if not leading the conference, the palliative provider has two main roles to fulfill. One, that of communication facilitator, and two, that of medical consultant. So when fulfilling the first role, the palliative provider should plan to augment communication throughout the meeting. And this is, again, after prepping the team on this approach in the pre-meeting. Examples of supplementing communication include asking clarifying questions from both clinicians and family, amplifying certain voices in the room, such as that of maybe the quiet patient or the surrogate or the bedside nurse that's been working with the patient for many days, allowing space for silence, so more time for the family to speak during the conference, ensuring the content of the meeting stays linear, and then periodically summarizing what has been expressed throughout the conversation. If I could pick one communication skill the palliative clinician should exhibit during the meeting, it's responding to emotions expressed by the patient and family. I won't dive deeper into this topic today because we could spend a really long time, but I know that there are already some great Friday Chalk Talks dedicated to responding to emotions, so insert them here for a deeper dive. And then for role 2 during the family conference, the palliative clinician might need to wear more of a typical consultant hat. So they might need to explain key tenets of palliative care. They might need to describe hospice and explore surrogate decision-making. And then sometimes the palliative clinician needs to be the one to take a step back and explore values again to help recenter the conversation, which ultimately helps the group get back to the aligning and planning steps, or step 6 and 7 of the family conference. Okay, we made it through the family conference, and the key point here is that it's best not to immediately disperse after the conference and return to our busy days. Instead, the palliative clinician should help assess whether it would be beneficial to have a member from the team remain with the family for immediate support and follow-up. This is a time when we can be more proactive about turning our attention to grief and caregiver support. It's also important to debrief with the interdisciplinary team for logistical and psychological purposes. During the team debrief, it's helpful to interpret how the meeting went and to acknowledge if there are any biases present, like the often present medical bias against aggressive medical treatments during goals of care conversations. This is also a helpful time to segue into assessing whether there might be any moral distress present within the care teams. And then again, if working with trainees, immediately following the family conference is a great time to provide feedback on their stated learning objective. It's helpful to highlight what they did well, to reinforce what to repeat in the future. And then specific quotes are helpful here, especially if they highlight a communication skill. And then it's also important to note that the palliative clinician should plan to follow up with the patient and family a day or two following the meeting, regardless of meeting outcome. This is a great way to demonstrate the sentiments of non-abandonment we often try to share when practicing palliative medicine. So to help summarize the last few slides, I included figure 1 from our article, which is an enhanced 7-step framework for the family conference. This annotated version contains a bit more nuanced guidance for the palliative provider, which is the resource that I was looking for when I started fellowship a few years ago. And then before we get to the discussion, I wanted to spend a few minutes acknowledging that everything I just said describes the ideal scenario, and that I'd be remiss if I didn't share that despite researching this topic and being interested in improving my skills, I've never hit all of my recommendations in one family conference. And that's probably for the best, since it would take a really long time to do everything that I just mentioned. So here are a few suggestions for using these tips in the messy real world. If there's not enough time to complete an initial consultation, plan to explore values during the meeting, especially if you notice that they aren't being highlighted by other members of the team who know the patient better. I find that it's helpful to have a tailored introduction if I'm a surprise attendee for the patient and family. Sometimes I'll say that my role is to help with communication optimization when many teams are involved, since it better explains my role in this setting. And then I know I can spend more time outside of the meeting explaining other aspects of palliative medicine. I make sure that we ask the patient and the family about what they're hoping to get out of the meeting before we start. So if I'm unable to set the agenda with the family ahead of time. And then lastly, when in doubt, and I feel like I'm going into a very sensitive situation unprepared, I remind myself that I find comfort relying on the basic tenets of trauma-informed care, which are meeting the patient where they're at, allowing time for grief processing, offering choices, asking permission, honoring preferences, and showing respect. You don't need to do any preparation to follow those tenets. If there's not time following the meeting, simply debrief when you can. Sometimes it's helpful to touch base with the team the following day prior to seeing the patient again. Sometimes it's impossible to plan everything and roles might not be defined prior to diving into the meeting. This is an opportunity to showcase our advanced communication skills and facilitate the flow of the meeting. You can say things like, Dr. So-and-so, I wonder if you could give the family a medical update now. It sounds like they last heard X bit of medical information. For lost rapport, so we all know that we say things that sometimes don't land well. It's helpful to apologize, follow up later, and again, just use those expert communication skills and some honesty. Say, I'm sorry, I didn't mean to upset you when I said X. And then lastly, it's helpful to accept upfront that a family conference will never be perfect. It's a complex process. It is our field's procedure, but it has so many variables that it's never going to be completely reproducible. I just try to make it my goal for every meeting to honor the patient and the family and to try to make everyone feel a bit more heard and supported throughout the process. With that, I'd love to open it up to the group now and hear your thoughts. Love to hear your experiences. If you have additions or edits to this framework, do you have a different checklist depending on your role on the palliative team? I'll just stop sharing now and see where the conversation goes.
Thank you, Lindsay. So in preparation for this, I was thinking, what are some questions we can start generating when all of this lovely information that you've put together that we would hope would occur with every family meeting inevitably does not, right? So, can you give advice or maybe real life examples of, when the pre-conference meeting and things you've agreed upon, whether it be roles or how we were going to present this to the patient or the options even we're going to present to the patient kind of go sideways once you actually get in the room?
Yeah, that's definitely some of the redirection skills shared on the slide for step 3 during the family conference. And so it's stepping in, and again, hopefully I've prepped the team that they're prepared for that and that it doesn't mean that they've done anything wrong. And maybe ask permission, say, I'm wondering if it would be okay if I summarized all that's been said, just to sort of regain a bit of control. And I also just make it clear that no one's done a bad job. It's so easy when you're the leader to lose track of sort of the flow of the meeting, and that I do see it as the palliative clinician's role to be the facilitator and to provide some oversight just to make sure that we all go in the smooth direction. So just kindly interjecting and asking permission is always helpful.
Thank you. Susan, do you have a question or a comment?
Yeah, Susan Merrill, one of Lindsay's co-authors. This was fantastic. This came out of a conversation that we had together when I was her attending when she was a fellow. I'm going to add something to the answer to Patrice, which is part of that is the way in which you debrief, which I feel like is often kind of multi-tiered, but I try to have a brief group debrief with whoever was leading from the primary team. And I always start that with, what did you do well, right? And even if they can't identify that in front of everybody, I'm able to say what they did well. And so I think that helps if you've jumped in and had to take over. Just 2 quick reflections to add. I think, and we didn't say this explicitly in the article, I think one of the things that we sometimes do is challenge the medical hierarchy in a way that benefits the patient. My favorite trainee comment of all time, which came to me in writing, was Dr. Merrill interrupted a neurosurgeon and it was okay. Right. And I was polite. I was totally polite, but people are not used to having the neurosurgeon be challenged in any way, even if it's, basically in a appropriate way. Right. And it was necessary to bring the family's concerns forward. And then I just wanted to, for anybody on the call that's in an academic center and likes writing, this is just an example of a paper. It took us a couple of years to get it published, but we just had a conversation after this where Lindsay asked me like, what exactly am I supposed to do? Right. And I was like, well, I can tell you, but like that should be written down. So if that's not written down, we should write that article. And we did. Thanks so much.
Thank you. Martin, you had a question?
Yeah, I wanted to share a story of when preparing for a family meeting goes wrong, and maybe invite either Susan or Lindsay or someone else to share a horror story of their own if they feel comfortable with such a thing. So shortly after fellowship, I was running a family meeting where we were talking about stopping dialysis, and it was a perfectly fine meeting, and we had buy-in from everybody, and the decision was made: roll in hospice, stop HD. But the next day, the staff changed, which is what happens in the hospital, right? Every week you have new everybody. And so this patient's long-term nephrologist was on service, and the nephrologist came in and told him, I disagree, you should continue. Patient said, whatever you say, I overwhelmingly agreed with his nephrologist recommendation. And sure, I was upset at the time, but you look back and that's beautiful, right? They had this relationship, this rapport of immense trust. And it took one sentence to undo hours of conversation. And so since that day, whenever I'm preparing for meetings, I try to ask about relationships with clinicians, in particularly whatever the main disease is. And it can be something as benign as, hey, I see Dr. Jella is your oncologist. Tell me about him. And you can tell pretty quickly, right? You're either going to get that some answer, or you might get the kid in the candy store who lights up and they're really excited and they want to tell you about Dr. Jella or whoever it is. And I know that if that's the case, I need to have buy-in from that clinician, whether they are working or not, whether they're even involved in the case or not, because, and it can be helpful both ways. I can say, hey, I talked to Dr. So-and-so and they agree with this recommendation, and that may give me more clout than anything else that I have to say. Or the other way, just making sure that they are looped in so that they are not changing something on the back end. So.
Thank you. That's a really good tip.
Yeah, I think that's a lovely pearl. I wrote that one down. I can share just last week, when we were asking the patient's family their agenda. So it was the primary team, third-year resident was leading the conference. And the family's agenda sounded a lot like very detailed medical questions. And we took a pretty long detour into answering very specific medical questions instead of what ideally would have occurred is putting a pin in each of the family's questions that they had that they were hoping to address. I tried sort of using my more meta communication skills by saying it sounds like being really thorough and detail oriented and knowing all of the options sound important to you. Sometimes it just doesn't work. And you just got to use time to get back to where you're trying to go. So that's my flop. That happened just last week.
I don't see any hands raised or anything in the chat. So I want to thank Lindsay Vendetta for being with us today and presenting this and being vulnerable and telling us how you got to this article. This was really great. So thank you so much. And everyone have a great day and weekend.